Hey everybody, welcome to Dental Nachos TV. This is Paul, Dr. Nacho Goodman, in my authentic Sunday dad wear. We have an amazing show for you today with my good friends, the Perio Amigos. They're going to wow you with their soft tissue grafting, soft top chef excellence. But we have a few announcements, especially an awesome presentation from our sponsor for a few minutes, who can start her video whenever she would like. And I also have my awesome team member who was willing to work with me until the Eagles game started. So if you are here and you would like CE, she will put the registration code in the chat. You register there, and at the end, I will give you a code and you'll get a free 1 hour of CE. I know my dentist people, I know you love free stuff. So I have the awesome Kristen here from Amigos. One of the things we like to do at Dental Nachos is showcase our awesome key resources and sponsors and what they do to help us cry less inside, Kristen, and enjoy our dentisting lives as much as possible. So Kristen, what do you do in your daily life to make dentists happier?
We get them paid. So we work with insurance companies and their patients to bring in revenue to all of our clients. General.
I love what you guys do and the concept of what you do, because I've been a dentist for 19 years and this was not available when I was first practicing. So just break down, what does Amigos do? Like, I think you make the office manager and the front desk team the most happy. You make the dentist second happy by getting money, but you really take a lot of annoyance off of the plate of that admin team. How do you remove that annoyance? Why have you guys signed up to take this annoyance on your side?
We've signed up because we have a lot of data analytical people focused to bring in the revenue and to bring in that time. That's the office managers and the patient leads are the ones that know your patients, that know their kids, that need the time to talk to them and talk about their treatment. We can't do that remote, but we can get them paid. So we bring in a lot of hours back to the rock stars in your office to treat your patients better.
And I mean, following up on insurance claims, even under the best of circumstances, not the most fun job in the office. And what we're really doing is we want our team to connect with patients, to be able to spend that time. And it's very hard. You get very distracted doing that. It annoys you. So, I mean, I love what Amigos does. If someone's thinking, you know what, that sounds great for me. I've lost team members during the pandemic. The ones I have are stressed. I would love to outsource my insurance billing annoyance to Amigos. How can they do that? And what do they learn at the demo? What is the demo like for this?
Sure. So we do a practice analysis for all clients that are looking to come on board with us, where we can show areas that we can improve. So the bottom line is just to get started with me, shoot me an email. I'll put my email in the chat and on our landing page. And then we'll reach out and we'll pull some numbers. We'll do a financial analysis and we'll see where we can go from there.
And I love that. You can also text Amigos, ABITUS to 215-543-6454. I'm a big just do the demo fan, Kristen, because you can learn, you can figure out how to make your life easier. And the demo, our favorite thing, dentist, it's free, just like this CE. So why don't you find out how you can decrease annoyance for free? Kristen, do you have any practices you're working with right now? How long have you been working in the dental industry for?
About 15 years.
So prior to that, you were not contaminated by dentists, but now you can't even remember what it's like not to know dentists. But our people, the dentist people, not exactly the most trusting people out there, not exactly the easiest with change. Do you have any clients that were like, man, I don't want to do this, but I'm going to do this, and now they are super happy that they're doing it? Do you have any stories in mind?
I think all of our clients, right? So we have one client that particularly was very hesitant, but he had no choice. He was down to a 48% collection ratio and couldn't find anybody to do the job. So once we got him back up into the 90s after 3 months, he has referred several other doctors to us, and he's kind of a good friend now.
That's awesome. I mean, I appreciate what you do. My whole goal is to kindly annoy dentists into making better decisions, kindly annoy dentists into crying less inside. So text Amigos, one of our key resources and sponsors, to 215-543-6454 to find out. We'll also share your landing page in the chat. So really appreciate your time here on Sunday. Kristen, you want to watch some high quality soft tissue grafting? That's great. But if you got to go back to your 5-month-old, we understand.
Yeah, I think I'm going to sign off, although I do have background in Perio, so it'd be nice to get a refresher.
Oh, nice. Yeah, Fadi and Dimitri are awesome. Thanks so much, Kristen.
Thank you. Bye-bye.
So that's what we do here on Dental Nachos TV, provide you with resources to find out how to make your life better, how to increase success, reduce stress, and decrease the number of times you feel like crying inside a day. So we're going to start with the Perio Amigos CE very shortly. We're going to play a short video While this video is playing, it would be a great time to register for the CE in the chat. You can earn 1 hour of live CE on TV for watching in on the show. You watch in, at the end there's a code. You put code into the registration link and you will get CE. If you're watching this in the future, sometimes we have on-demand CE where you answer a short quiz. Sometimes it's just awesome content for you to learn. If you have any questions about CE, just email ce@dentalnachos.com. So enjoy this short video here for a second, and then we will get started with the Perio Amigos. Drew, is it a good idea to take a job without having a dental focus attorney review your contract? Yes or no?
No.
Good answer. Finding your first job in dentisting is not easy. Hiring your first associate, also difficult. I have created Dentist Job Connect to solve this problem. My name is Paul Dr. Nacho Goodman, founder of Dental Nachos, and connecting dentists for jobs is one of my favorite things to do. It embraces our amazing Nacho spirit of collaboration, community, and helping each other. To learn more how we can help you, text JOB to 215-543-6454.
Right.
Okay, hi.
No, you go.
Hi, I'm Jill, Director of Dentist Job Connect with Dental Nachos, and I have one of my clients here who's going to share about the success we had with our program.
So I'm Ankur, I'm a dentist in Ohio, and we were getting to the point where we needed an associate, and we didn't know exactly how to get an associate. I decided to post the position on Job Connect with Dental Nachos. It's 2 months only, and we already have an associate hired. It's been awesome.
It's been great to work together. Can't wait to work with you next.
Hey, denting friends, it's Paul. I am ready to go into my office. Well, not quite ready just yet. I like to sit in the car before a day of dentisting and get myself in the right frame of mind. What I do, I remind myself, keep your sweating on the outside, you're crying on the inside. You're a dentist, Paul. That's where you keep your crying. Keep your crying on the inside. Now I'm ready to go in and be a practice owner, a dentist, manage that practice or circus or practice. I mean circus, where the animals don't try to eat you, just slowly annoy you to death. Hope you guys have a great day. Dentisting is not easy. Let's collaborate more. Let's communicate more. Let's build a community that cares together. Welcome to Dental Nachos TV. This is Paul Dr. Nacho. I'm in my authentic dad weekend wear today, and I want to welcome you to Dental Nachos TV, a TV channel for dentisting humans to help you do 2 things. Cry less, smile more. Cry less, smile more. I have my little guy here. This is you, DDS. There's so many things that make us cry on the inside and sometimes the outside part of our dentisting bodies. The little class 2 ring thingy flies across the room, pings around the floor, and you look at your assistant and say, "Can I have a new class 2 ring thingy?" And she shows you the box, and all that's in there is a sterilized mango pedo ring, and you're doing a giant class 2 in number 15. You have to look down at that box and say, "Perfect, just the one I wanted." Sometimes your amazing team does an amazing job fighting over who took the last box of lidocaine. So what we want to do at Dental Nachos TV is help you be a happier dentisting human. Work on your dentisting core. 1% better, like one of my favorite human beings, Kristen Bell, likes to say. How can we annoy ourselves just a little bit less each day to be a little bit happier? I want to share with you some resources from Dental Nachos right here. So you can text any of these words one at a time, not all at the same time, to 215-543-6454. If you're watching Dental Nachos TV live, I would love for you to ask questions in the chat, in the Zoom chat, in wherever we are. Ask questions. I love customizing what we do to you. If you're watching this on demand, just shout the questions at your TV and I will hear them. Just kidding, I won't hear them. But what you can do is you can text me these questions at 215-543-6454. So let's just go over these words and what you get if you text these words in. Totally up to you if you want to text 1, 2, 3, all, or none of these words. first text KARMA to 215-543-6454. That will give you a $200 CE gift code for you to purchase on-demand CE. You can purchase on-demand CE about Class 2 composites, sleep apnea, cosmetic dentistry, implants, buying a practice, managing a team, and more. Text DREAMS to 215-543-6454. You may have a dentisting life situation, like finding a job, hiring an associate, buying a practice, selling your practice, or just being incredibly stressed, and you want to ask me about it. These are super fun, super affordable calls with me that also come with a great resource as well. If your team is missing, you have to look down at that box and say, perfect, just the one I want. Okay, guys, so we are going to get started with my awesome friends, the Perio Amigos. I want to welcome you to Dental Nachos CE on TV. If you're watching in live, you can get live CE on TV. Just register at the link that my team is putting in here. I want to introduce you to my good friends, Dr. Fadi Hassan and Dr. Dmitry Ivanov. I found a weight that Fadi used when he was 5 years old to do curls, so I'm going to use them during the show. Fadi's a very in shape person. We're going to talk about the evolution of soft tissue grafting. This webinar will review several techniques in gingival augmentation, utilizing increasing the zone of keratinized tissue, and root covered procedures utilizing autogenous and non-autogenous donor tissue. Understanding the diagnosis of mucogingival deformities, pros and cons of different approaches, and decision trees. So welcome, Fadi and Dmitry, back to Dental Nachos CE on TV. So glad to have you guys here. I'm going to let you guys present. We'll do the CE, then we'll talk at the end about your amazing course coming up in Philadelphia, second time this year. More LVES, more soft tissue grafting. But I'm going to turn it over to you guys.
All right. Thank you so much for having us, Paul. And it's good to see everyone on this Sunday morning, or afternoon, in other words. Let me share my screen and we'll start rolling here. All right. So first of all, I just want to thank you, Paul, and the entire Dental Nachos team, honestly, for making this possible for us. It was great to see you guys in Philly in July, and looking forward to seeing you guys again in November. Today, just to get, like Paul was saying, me and Dimitri are going to be talking about some soft tissue grafting. Dimitri's going to have a great start with us, and I'm kind of going to be guiding the slides while he has a chance to kind of talk about all the slides. Then I'll jump in at the end, and then hopefully we'll have a chance to answer a few questions if you guys have any for us. So again, for me and Dimitri, we made something called the Perio Amigos, which is kind of a soft tissue workshop dedicated for that's 2 days. We'll get into it at the end of this discussion when you guys have more questions for us. These are our IG handles, so please feel free to follow us and check our cases, and hopefully we won't disappoint any of you guys. From now, I'm going to have Dimitri kind of go on, and I'll have him start, discussing the first slide for him. So all yours, Dimitri.
Dimitri, I think you're still muted.
Oh, good morning, everyone. Can you guys hear me now?
Yes. Yep.
Okay. No wonder no one's responding. Thanks so much for the introduction. Nothing is better than to chat about soft tissue on a good Sunday morning here. I know it's afternoon for you guys. We've done this so many times with Fadi that we, talk about cases back and forth, especially on Instagram, Instagram Live. So it's kind of fun to do this again over with Paul. So, this presentation will be mainly a case discussion, which we're going to throw in a lot of kind of diagnostic things. So this first slide just merely represents how we look at diagnosis of a soft tissue lesion when it comes up, in terms of the recession. Usually we look at the amount of keratinized attached gingiva to determine whether the tooth with or without recession needs some sort of augmentation. So if you look at the left side, you have a narrow zone of keratinized tissue, but if you put a periodontal probe into the sulcus, the periodontal probe will not pass the mucogingival junction. So that generally we call a minimal attached tissue, minimum zone of attached tissue. So you have at least 1 millimeter of attached tissue at the mucogingival junction. In the right picture here, you guys can see very much no keratinized tissue remaining. There's a recession. And if you put a periodontal probe in a sulcus, you'll pass the mucogingival junction. So that right side diagnosis would be mucogingival problem. So obviously this type of defect or mucogingival situation requires some sort of grafting. And we'll go over a couple of techniques today. And it's a very short webinar to really cover a lot of these details, but we'll try to hit up very high points on diagnosis and kind of treatment planning. So that's how we generally look at, and majority of offices, Perio is evaluated first time usually by the hygienist. So hygienist must be able to probe, must be able to measure the amount of attachment. Always document recession on your periodontal charting, because I know a lot of you guys, if watching maybe general dentists, some of the general dentists may not chart the recession or remaining attachment level, which is very important for the diagnosis. So those are the things that, looking at the remaining attached tissue is what's important for the stability and, coming up with the treatment plan. So let's see what we have up next. What's the next slide, Fadi? So yeah, so you guys can see basically, is what I already said. The left side was a stable situation. Majority of times we don't have to treat that. On the right side, we have to treat it, and we'll give you guys a couple of diagnoses. Around implants, which Fadi is going to cover a couple of things today with you guys, is a soft tissue around implants is very, very different than around the tooth. As you can see, implant can actually coexist. If you look at the picture C, implant can coexist with ample amount of keratinized tissue, but it doesn't mean that it might be all attached. And implant can also coexist in the tissue in the picture D that completely surrounded by mucosa. Obviously, picture C and picture D are not as stable as picture B, because you could see that there is keratinized tissue, but keratinized tissue that's firmly attached to bone. So that's kind of the key factors to have that keratinized tissue, not just keratinized tissue, but attached keratinized tissue. And Fadi is going to show you guys some of these. So there's so many etiologies. We can talk about this for 3 days with Fadi about each of these pictures and how and why they are caused. But the etiology is very important to understand, whether it's brushing, grinding your teeth, flossing trauma, malocclusion, malpositioning of teeth within the housing. Those are all different reasons why the recession happened. But I think it has to be understood first. Let's go to the next slide. Just quickly about Miller classification. This is very basic overview of Miller classification. It's just a communication thing between the dentist and between you and the patient. Miller 1 is basically a recession that does not extend to the mucogingival junction. You have no interproximal tissue loss. Miller 2 is recession goes beyond the mucogingival junction. You still have no interproximal bone loss. Miller 3 is when you have interproximal bone loss and the mucogingival junction, recession is passing mucogingival junction. Miller 4 is when you have severe interproximal bone loss. And generally, grading these between these two, Miller 1 and 2, generally you should expect complete root coverage or almost complete root coverage in majority of cases. Miller 3 is only partial root coverage anticipated. Miller 4 is when you don't anticipate any root coverage. So a very simple tool. It's great to communicate between you and the patient, because you can set the expectations right from the beginning. When you're showing these either a case to the patient from before, they shouldn't expect like this Miller 3 and 4. There is no way we can achieve any root coverage. Or when you're discussing it with another doctor, like a referral, you can explain that the root coverage in these cases are not feasible or not possible, but it doesn't mean that documentation should not be done. We should still treat the tooth and be able to stabilize any further recession from happening. All right, and I'm going to start with the first case. We're going to go back and forth with Fadi about a couple of cases. Fadi is going to show a case. I'm going to show a case. So we'll cover a few cases, and this is a relatively, or one of the few techniques. And Fadi, do you use this technique yourself?
I do actually. So what's interesting, I was looking through my older cases and I found a case that I did in 2016, 2 years before this study came out, that I did actually laterally closed tunnel and was able to find the post-ops for that case. So I was like, I wonder if I should have had the opportunity and Gus maybe publish something like this before this one showed up 2 years later. So it was a coincidence. Looking at my old case, like, damn it, I missed it. I missed that opportunity.
Honestly, I don't think you're alone, because I've had cases exactly like that, and the entire world's had cases like that, because this is not a very innovative technique other than
Exactly, it's
what
not.
you're doing. We just haven't been able to publish it like these two guys in 2018. But
I know we should have met. We should have met sooner, me and you, Dimitri. I think we should have published
exactly.
this like a long time ago.
Exactly. In residency, we would have published that article, because I've had cases where I never even knew that this technique existed, and then I look at my post-ups, I'm like, I think I did this a couple of years before. So great technique for lower anterior incisors with a deeper narrow recession. Basically, it's in a conventional tunnel, like a Pat Allen described, many years ago. It's a basically graft goes into the tunnel, and the recession is basically zipped up towards the gingival margin after it's released. So let's go to the clinical case. Just to review, Fadi and I, we've kind of changed a lot the way we harvest tissue, and Fadi, you're probably in agreement. We do a lot more deepithelialized harvest than the conventional subepithelial for various reasons. The speed of harvest, the healing, the pain is less. I find the quality of the tissue is better, right?
Especially the quality, absolutely, 100%.
And the volume, right? We can harvest so much more using a deepithelialized versus a conventional subepithelial lengthwise, and also the volume. I mean, we could harvest enough for a full arch, even if you're doing it bilaterally, right? So we could utilize those. Autogenous steel gold is, nobody can argue with that. Studies been written and proven. There are substitutes. I think I'll show you guys an allograft case. Fadi does a fair number of allograft cases. We've also switched from different materials that we used to use. Maybe like in residency, we used a lot of the most common alloderm, which would switch to other substitutes. And then there's xenografts. There's Ossic Volumax and FibroGuide now in the market. Do you use any of the substitutes other than allografts, Fadi?
I'll say I don't use much of the. I don't use much of the Ossic Volumax or the FibroGuide. Maybe I've done it in 2 cases total in the last few years, but I definitely would say the dermis tissue, the allografts is kind of my number one. If I have multiple recessions on, especially the maxilla, to be specific. So
that's from Zimmer, correct? That's Zimmer.
I use the one from Zimmer. Yes, I have used the one from Salvin and Straumann. They're phenomenal products. Definitely. I've used them, and I even used Alloderm in the past. So it's sometimes we just go through those phases where we like to try different products and see which one really works best in our hands to get the best long-term outcome. So right now I've been very happy with the Zimmer product. Again, I've had also phenomenal results with the Salvin and the Straumann products as well.
Yeah, I'm in the Salvin and the Straumann camp too, even though few times a year that I really need it, I do utilize those. It's quite nice because of the thickness. Right, so let's look at a case. Just the case that we discussed is a lower anterior. As far as the treatment options, if you ask 5 periodontists, they'll probably give you 5 different ways to treat this defect, right? Right, Fadi?
Absolutely.
As far as the Miller classification, what would you call this?
This is a perfect Miller class 2. Almost bordering a class 3, but I would say it's not there yet. But you can see there's a recession. It's going pretty much beyond the mucogingival junction at this point in time. And so it's nice, it's an isolated defect. So, I'm going to have you, and the question is about materials of choice. It's a bit like what Dimitri was saying. There's so many different techniques, different materials you can utilize for a case like this, whether it's a free gingival graft or a connective tissue graft or any kind of dermal tissue matrix. So it just depends on what your comfort level is and what techniques that you've been trained to do to get the outcome that you've had. So, I'm going to have Dimitri show and discuss this beautiful case, and you guys are going to see the result and the outcome of this one, which is definitely not an easy one. It definitely has its challenges. But yeah, go ahead, Dimitri. This is explain to me what you've done here, how you did it, and the materials of choice.
So yeah, I agree with you. Like I said, if you guys follow or anyone follow us, we have a lot of friends on Instagram that would give you at least 3 different options. Majority of would say I'll do a free gingival graft, right? Which would work well in this area. I sometimes struggle between deciding between the two because I do love the strength of the free gingival, but then I love the aesthetics of a non-free gingival graft when we can do this right. So in these cases, I've definitely started using a lot of laterally closed tunnel. I incorporate a Vista technique, which is another technique that we'll discuss. This is, if you can see the hole right here, I call it 3mm hole on the right apical to the area. That's where the tunnel starts from, and that's where the graft is introduced through. I modified this technique a little bit, as you can see this. I don't know if you can appreciate the sling body that I did.
Is this the sling on the lingual to stabilize the graft?
Yes. Yeah. So it's just the sling through to the lingual to pull just the graft alone towards.
Yeah, I love that. I love that. I love that technique.
It's just a little extra stabilization for the graft. I find it for thicker grafts, it's much harder to stabilize those as coronal as possible because the tissue wants to push it down. So that sling, it's from a technique by my friend. His name is Jonathan Doe. He published a paper. It's called internal, some kind of internal suture. But anyway, he invented this technique to lingually stabilize the graft, even without any suture remaining. He just leaves it the way it is, like this, right? He puts a sling, he does not zip up the recession, and he lets the graft be exposed like this.
Oh, wow.
Yeah, very cool. So basically, this is a deepithelialized graft that was taken. The tissue was released from the inside, basically the entire area. If you guys can appreciate, at least 2 papillas on each side. So 1 papilla on each side of the tooth that we're being treated. The graft is inserted and stabilized around the tooth with a sling suture and a couple of interrupted sutures on each side of the graft. And after that, the tissue is simply zipped up from the base of the defect to the coronal. So we always start at the base of the defect because it's the area of least resistance at that point. And as you zip it up coronally, you're going to decrease it. So just simply looking at 3 weeks follow-up, as you can see, there's 100% root coverage. As you can see, complete regeneration of keratinized tissue and thickness. And we let this heal for another couple of months, and we can kind of really appreciate the stability after this. Go to the next slide, Fadi.
So a question before we move on is, does this patient have any history of like orthodontic therapy and anything like
100%. Great question. And I see this very, like 99% of the time, I will be able to, number one, guess that the patient has a lingual retainer of some sort. Like I see a ton of, usually it happens with like a wire retainer on the tongue side. So patient did have orthodontics, and it's always single tooth. I mean, you see this ton too, right, Fadi? So orthodontics, single tooth, post-ortho?
Absolutely. I would say maybe 90% of the recession cases that I do treat in my private practice, it's a history of ortho. It's amazing. It's usually anywhere between 5 to 10 years later. Mostly right now, my patients that I'm seeing in their mid to late 20s. One easy thing for our general practitioners who see a lot of those cases, or even for our periodontists, is just simply look at the roots in the pre-op picture. You can see almost the 4 incisors, the roots, and even the canine, they're almost about to stick out of the gum. And you can see how that, the kind of the effects of those roots can almost that festooning deep effect. And that's very common. Just simply put your finger in and you can see the waviness of those roots. That kind of tells you that there has been some form of orthodontic therapy that was done to this patient. So that's one indication, one way to really find out, before even asking them. So, but just to give you an idea, I mean, it is very, very common, and something we always like to educate our orthodontic colleagues. Hey, this is what's going on. Just keep an eye on it if it does progress or does develop in the future.
Dude, 100%. I call that appearance a washboard appearance. You know what a washboard is? When you're washing clothes, those little ribbed area, you wash clothes.
Oh, yeah.
You're from Middle East. You know what the washboard.
I know it for a fact. I've seen it for sure.
Yeah, it's called washboard because you can rub it against your fingers and you'll feel like those ribs. So going forward 2 months, as you can see, the area that I left slightly exposed, it fully keratinized. And the beauty of this technique versus the, let's say, free gingival graft is that we gain tremendous amount of keratinized tissue and thickness, but in appearance, it blends in a lot better. So it doesn't stand out like the patch, the way we call a tire patch appearance. So that situation, I think, is absolutely beautiful from the standpoint of the technique. And What do you think about using, people would ask us, would you use an allograft in this situation, Fadi?
I think me and Dimitri, the nice thing is that we always have like our own decision trees. One thing I've noticed is that anytime we use like dermal tissue matrix, I think the least favorable location to use is going to be the mandibular anterior. It's just, unless you have an abundance of keratinized tissue, it works really well. But when you have a case like this where there's very minimal tissue, there's gum and gingival inflammation that you can see, our own tissue just works the best. It's more resistant, it's more resilient. And if anything, look at it 2 months, it's how thick it is. Most likely that will stay like that maybe for the next 7 to 10 years easily, maintaining the same thickness, if sometimes not even getting thicker. We just don't see that result consistently, unfortunately, with dermal tissue matrices. And I've been doing this for almost 6 years now. I see my own cases now where I've used it in the mandible, it thins out over time, and sometimes even recession can develop again, even whether it's a year later, 2 years later, and sometimes as early as 6 months later. With our own tissue, if anything, it just gets better with time. It's like fine wine, it just matures well over time. And I think we can all agree that all the periodontists out there who do this a lot, I think almost all of them will agree that our own tissue just has that superiority when it comes to mandible, especially anterior mandible, more than anything else.
100%, 100%. And also the most important part is the inability to regenerate keratinized tissue with non-palate tissue, because alloderm will not turn into this quality keratinized tissue if you can't leave it exposed, first of all.
Absolutely not.
Like here, if you leave a little connective tissue exposed, great, you're going to gain more keratinized tissue. So yeah, I'm 100% with you on that tardiness, Fadi.
All right, so I know. So Dimitri, what I decided to do is I'm gonna have, because you did your slide so perfectly well with the Miller classification. So I'm gonna have you do a beautiful job, just kind of continuing with the Millers, and then I'll jump into the implants. So we'll have a nice teeth versus implant scenario. Okay.
100%.
So I'm gonna have you continue with your slides, and then I'll do mine at the very, very end. Okay.
So that's another question we get a lot. Can you cover abfraction lesions? I get this a lot of questions on social media and also from general, practitioners that refer cases to you. Like, what do you do? Or can I put a composite on there instead? What is your response, Body, to these kind of questions? Can you put a composite there?
Great question. So it really depends on how far does the abfraction extend, number one. Is it extending also all the way up to on the enamel as well as the root structure, and how deep is your abfraction? So if it's extending too high, for example, like this is a beautiful case by Dimitri, but you can appreciate that a lot of it is happening a part on the root structure and part on the enamel structure. I love to, first of all, kind of smoothen it out and make sure it has a nice blending to it. If it's a deeper than 3 millimeters, I will most likely at least create a new CEJ. And I usually tell my restorative doctors, can you please create a new CEJ just to kind of, compare to the contralateral side if it's intact. And then I will do my best to kind of currently advance everything else with a soft tissue graft. If it's a shallow one, a lot of the times donor, just using any kind of tissue matrix, whether it's donor tissue or autogenous, it does a really good job actually masking that and kind of covering those abfraction lesions. What about you? How do you approach this yourself, Dimitri?
Same as you. These exactly. There's a root portion, and you have to explain this to the patient first. To accept expectations, because sometimes patient comes in with this abfraction that's above the CJ, and they're expecting the whole thing to be covered with gum, right? So yeah, you're right. If it's above the CJ, you either restore that with a composite. The restorative doctor can do that. Or in a lot of cases we just leave it if it's not aesthetic area. Smooth it out. I always try to decrease that sharp ledge prior or during my surgery, and then obviously we can all try to restore the CJ at a later time. Also, if let's say you didn't cover as much as you wanted to, so that's kind of the decision tree, whether restore it now or restore it later. But same thing with just like you said, if it's very deep, you kind of have to put a restoration in, especially the coronal portion, so you can get some of the CJ back. Miller classification wise, it looks relatively straightforward. You know, all the tissue and approximately fills in nicely. So I'd call it Miller 1, Miller 2, if depending on where the original mucogingival junction was. So Miller 1, Miller 2, obviously we can expect 100% wound coverage, right? This is actually a patient who's undergoing ortho, following ortho. So we, Body, you yourself probably get a lot of ortho clearances or pre-orthodontic treatment. Right,
Absolutely.
So you like to treat these mucogingival problems prior or after orthodontics?
I would say 90% prior. The only times that I would have my orthodontist start before I would do my soft tissue, if there's just too much severe crowding that I know for a fact that I won't be able to pass my needle and my suture.
Yes.
That's the time I will actually really talk to my orthodontist, pick up the phone. It's like, can you just, do very minor orthodontic movement just to help me open the context a little bit, and then pause it. Let me do the soft tissue grafting. Give me just 2 months of healing, and then go back, continue orthodontic therapy. So ideally 3 months, minimum 2. But just to give you an idea that, it's always good to have some good contacts where you can just allow it to go through, because sometimes you would like to jump the gun. Let's get it done quickly. Let's do the graft first. And you're in the middle of surgery. It's like, oh, shit. I can't pass my needle through. And I was like, what am I going to do now? So just something, always kind of check with a floss. That's the easiest thing. I always like check with a floss during my exam. If my floss can go through easily, maybe I can get my my suture through it as well. So that's one trick.
Good. Yes, 100%. This is the most horrible experience where you're open everything and you can't suture the thing in place.
Oh yeah, I've done it before. I'm telling you from my own mistakes, so we always
guilty as charged. Yes, I'm guilty of that as well. So I'm with you prior to ortho, except some of these situations. I absolutely get them treated quickly, open it up, and do the soft tissue augmentation. So this case was treated as a Vista technique, and again, this Vista technique is very you could be used around implants. This technique could be used around the roots for whether it's an augmentation. It could be used with variety of materials as well. So in this case, again, we're using a de-epithelialized pregingival graft. Basically, it's you take a pregingival graft, which is epithelial graft, and you remove the top layer of epithelium, just leaving a very good quality connective tissues. You can see it looks very white and dense. Is because there's no fatty tissue, no glandular tissue. That's kind of the reason why, if you look at the Zucchelli paper, who introduced this technique to us, he actually found that this type of graft shrinks less over time because no fat, and it actually grows thicker. So this is a kind of an overview of it. You can see if you remove just the epithelial layer, it's very thin. I mean, there's not a lot of cells to remove there, right? It's you can remove it intraorally or extraorally, and is what you can see in the right picture. What you're staring at is the highest grade connective tissue, the most superficial connective tissue, right? And that's what you can harvest intraorally, or you can harvest FGG on the tabletop, the epithelialized. And we go in a lot of details with the techniques, how to do it in our course, but it's just a quick overview here. You place the graft through the Vista incision, through that little vestibular incision that we made, and we coronally position everything with the slings. So this is called an interrupted sling, just a simple interrupted sling introduced by Pat Allen. If you guys familiar with Pat Allen technique, this is basically the most simple technique to coronally position tissue. You bite through the graft, you bite through the flap.
So that's what I'm asking. So do you usually like to grab both flap and graft simultaneously, or sometimes do you see yourself, stabilizing the graft first? And this is what Pat Allen used to do when he first came up with the tunnel technique. He used to stabilize the graft first, and then he would come back, and then he would coronally advance the tissue. But again, that's changed over the years with his technique.
He did.
So how do you do it?
So whenever I'm doing autogenous tissue, I do it just like Pat Allen. I bite the flap and the graft together. But if you look at the Zade paper and the way Zade taught the Vista technique, the original Vista technique, the slings, basically the flap was secured first, and then the graft was introduced second. And in his original paper, he did not use, obviously, if you read this Vista technique paper, he did not use any autogenous tissue or any allograft. He actually used a sponge soaked in a PDGF, right? He used the PDGF with some sort of a material like a sponge or something. So he secured the flap first, and then he introduced the second. And I do it both ways. I do the flap first, the graft second in allografts, because allograft is big usually, and it just gets stuck to the bone inside. But with autogenous, I do both. I advance with a flap. So as you can see, 6-week follow-up. And when do we remove sutures, Fadi? I remove sutures at 3 weeks. You remove sutures at 6 to 7 weeks usually, right?
Yeah, so actually recently, obviously in the last couple of months, I think since we did our course together, actually sometimes I've been removing them as early as 2 weeks. I've had some cases, especially the ones that are loose. So yes, I do keep them most of the time at 6 weeks, I would say, but the least is like 2 to 3, and again, very certain cases.
3 is what Zade recommended. I think if you read Autozur paper or Autozur book, the Pink Bible, they remove sutures at 2 weeks, and they start hygiene like at 2 weeks with the coronal brushing and all that good stuff.
So I do the same. So my hygiene starts at 2 weeks with coronal brushing. I call like this sweeping motion.
Sweeping,
yeah. So you start from the gum all the way up, about 10 to 20 sweeps in a coronal direction, and that's good for. And I make them do that for at least the next 2 weeks until I see them at the 4 weeks or the 6 weeks post-op, and then slowly start introducing like more flossing, how to floss carefully, and and the brushing techniques, just kind of going over that with them.
Yeah, same thing. I do start at the 3rd week with the coronal brushing, because I take out sutures at 3 weeks, but exactly just like you said, coronal brushing, no touching tissue until basically you get mature tissue. So that's 6 weeks follow-up. You can see the beautiful result. Thickness is phenomenal. I mean, nothing gets better than a deepithelialized, even though you take thinner graft than
it thickens with time. That's what I've noticed. It thickens
with time, just like a fine wine gets better with time. Absolutely.
Absolutely.
Yeah. Thinner grafts, but outcome is thicker. Kind of oxymoron, right? It's the opposite. We used to think we got to take thick subepithelial graft to get thick result. Here you take thinner graft and you get massive thickness. So and patient experience is better too. What is it, Fadi?
What's amazing about, if you guys see the results here with Dimitri's case, is that you can see even the abfraction lesions, they're pretty much almost 100% even covered. It pretty much covered even the portion that where the old CEJ was, where now it's all gone. It's kind of almost onto the enamel surface as well. So that just shows you the quality when you're using autogenous tissue, what kind of results you guys can achieve with it. So if anything, this is above and beyond what anyone can always achieve. So this is an incredible outcome, and you can appreciate also the tissue thickness that Dimitri was able to achieve that from that occlusal shot. And again, like, that's stable. It doesn't get better than this long-term wise.
Yeah, one thing that a lot of doctors don't appreciate is the mucosa portion. If you look at the extent of the graft into the mucosa, this mucosa is firmly attached. So you actually deepen the vestibule even beyond the mucogingival junction, so you can see the outline. Because that tissue is so attached, that mucosa is very firmly bound down. So it's not just the keratinized portion that gained good result, but it's also mucosa that's firmly bound down. Yeah, functional mucosa. I think Pat Allen calls it functional mucosa in his
exactly.
So that's an interesting case. Cases.
Tell me about this one.
Yeah. So this was she's actually an Olympian from South Africa. She's a runner, really like 6'6", female, super cool lady from one of my offices. So we been, obviously a lot of perifunction, a lot of grinding their teeth, a lot of, as you can see, a lot of chipped teeth. So she's undergoing now orthodontics to get things right. We got a couple of implants for the posterior support now. But first and foremost, prior to orthodontics, we wanted to get the soft tissue kind of back, right? And whenever we see a lot of, these are challenging cases because every tooth is restored with composite. How do you approach these cases, Fadi, when every case tooth is restored?
Question. I mean, so if you guys look at this, you'll see an abfraction on the second premolar, both sides, right and left. There's class 5 restorations. There's caries going on the canines. These are the cases where, when you guys sit down and kind of dissect it, first of all, those class 5s need to be removed. The caries needs to be controlled. So that needs to be done very carefully. And usually I do those during my soft tissue graft. So you know what, I'll numb the patient up, I'll gently reflect the tissue. In a case like this, I might consider tunneling it, for example, and then I will kind of gently just push the gum down, like with a very fine instrument, and then I'll work my way gently on removing those composites and any kind of decay that's available. That's you know, if I find anything. If the decay is too deep, I might use like a GI restoration, and I'll put a small amount of it on the root surface once I've cleaned enough, and then I'll able to coronally, you know, use my tissue to coronally advance it later on. But I mean, again, it's cases like these, yeah, they're tough, they're challenging, but they can also be very rewarding once everything's nice and healed. So what did you do in a case like this, Dimitri?
Dude, removing composites is the most pain in the butt thing that you can do, because you cannot tell sometimes which one is composite versus what I started using. You know what helps me? There is a black light that you can buy for $10 off Amazon, and you shine it on the tooth, and it shows you if you remove completely or not. Because
oh, that's cool.
Yeah, composite lights up with a black light. Tooth structure does not. So you can use it.
That is very true.
Yeah. So you know who uses it? Most people that do Invisalign and put composite buttons. You can put it in on the tooth, and it shows you if you completely removed it. So that's a really cool pro tip. You guys can use.
It's your friend, Dr. Nacho. I'm just here to tell you, like in basketball, this is halftime for our show. So good job, halftime. I'm also going to ask one question. Maybe you saw it, Dimitri. Just want to give you guys a halftime 30-minute check-in. I do ortho frequently and agree this is a common problem. Is there any way to predict and possibly graft pre-ortho? I apologize if you answered that already, but I saw that in the chat.
We sort of, Fadi actually sort of already reiterated that the fact that we do graft most of the cases pre-ortho in 90% of the cases, but some cases with no contacts, like if I couldn't put through the sutures through these contacts, we would probably do ortho quickly and then graft it, you know, soon after.
Awesome. You guys are doing great. I can never get enough Perio Amigos. I'll be back in 30 minutes to interview you about your show. Enjoy, right. Crew. You're getting.
So let's keep going quickly. So yeah, I removed composites, which was pain in the butt. So this kind of case, we did a Vista technique again. Fadi already mentioned that it's not our favorite thing to use in the anterior mandible, which is an allograft. This is a Straumann allograft, which is thick. As you can see, it comes pre-hydrated.
It's very thick.
It's very thick. It's unreal how thick it is and predictably thick it is, because alloderm, I'm sorry, if you open it, it's like a crapshoot. You sometimes get a thick one, but never this thick. I've never seen alloderm this thick. So we created a full thickness tunnel. We placed the allograft into the tunnel, and I think this is where this is a complication case that I wanted to show you, because one of the canines, if you could tell, and this is a great aspect to take photography during, because you can go back and evaluate your sutures, where you messed up, you know, what went wrong. So
I want to ask one quick question.
Yes.
It looks like that you actually sutured the flap first before inserting the graft. Is it that what you did here?
Yeah, for allografts, I always suture first, and then I insert my allograft second, because a majority of times I do not actually have to stabilize allograft inside, because one, it doesn't move, like it gets stuck to the bone so much, and you really don't have to stabilize it. I did stabilize it here, as you can, if you look at the between the two premolars on the left side right here, between the number 29 and 28,
I do see it. Yeah.
There are interproximal bites through. They're just stabilization bites after, because my initial stability to the flap was achieved with slings, and then once I placed the graft, I stabilized it further. But a lot of times you don't have to. If you have a very wide piece, you know, you don't have to. So in this case, basically, this is the worst nightmare when the patient texts you with a question. Hey doc, does the white stuff supposed to look like this on my tooth?
Look like this?
Well, first of all, she texted me and saying, "Hey, I have this white thing on my," and I'm like, send me a picture. So it's a Saturday morning. We did surgery on like a previous Friday, and she texts me this on Saturday morning, and I'm like, that looks very bad. So basically what we're staring at is a piece of necrotic allograft. And if this was autogenous tissue, this would not be a
You
problem.
would never worry. Yeah, you would
It would
never
actually
worry.
be even better if it got exposed, right? So, but
So, yeah.
allograft, unfortunately, we can't leave exposed. So this is the allograft exposed. This actually go forward one slide, funny.
Here?
No, forward.
So
Forward.
it's
Yeah. So
before-
this is a no back. Okay. So as you can see, looking at the complication, that basically, I think if you look at my pre-op suturing, I think this area was just too constricted. I put too much tension there. That was my speculation. Could I have not removed all of the material from the root? Maybe, maybe not, because I don't think it would have caused it, but I think I strangled the tissue when I was suturing that canine, because the remaining tissue looks phenomenal. I mean, everything is healing really nicely.
You can see how thick it is. It's just unbelievable how thick that
massively thick. It's massively thick. And again, choosing biomaterial, this case had ample amount of thickness, ample amount of keratinized tissue, which is what made me kind of decide to not go with an autogenous tissue here. So yeah, 1 month follow-up. As you can see, there's a complication. Basically, we did not get any root cover, or partially we got root coverage, very partially, and the tissue is healing. That's because allograft was left exposed. And this is 2 month follow-up. As you can see, the remaining dentition got a really nice root coverage, beautiful thickness gain, but this area remains uncovered. So we let this heal for about 3 months total. We are going to retreat this specific area. I'm going to just do a simple flap here and just advance it like a linger style approach without any grafting, just to coronally advance it after I clean the root the way you do it after.
Yep.
So that's 2 month follow-up. So when you get to these severe bone loss recession areas, a lot of times we ask our questions like, what is the goal of the treatment, right? Is the goal root coverage, or is the goal to create better quality tissue? So if the root coverage is not possible for me, I generally would go for a free gingival graft. If the root coverage, even though you can still get good root coverage with free grafts, but in this kind of case, I just decided to go. And Miller 4 defect is when you have an approximal tissue loss that's severe enough that may not warrant any root coverage. So how would you treat this case if you were me, Fadi?
Like you said, either free gingival grafts. What I've been noticing myself recently in the last maybe year or two is I've been doing more connective tissue grafts. My aim is not root coverage per se, but just to kind of thicken the tissue. And like you discussed earlier, sometimes it's good to have just kind of a bounded keratinized mucosa, but it's attached mucosa. It's non-movable, but there's a firm tissue underneath it, which is your connective tissue. So, whether you use a free gingival graft, again, it's more sturdier, definitely looks more stable, not going anywhere for the next 50 years. And I tell my patients, you'll die most likely before the graft will die, because that thing just lasts forever, in other words. But again, you can go with either one. So age of the patient is a major role and factor as far as what choice of technique that I'll be going with. So I guess what you did here was one hell of a free gingival graft. That's like from two sides of the mouth for sure.
That's right. So we call it a snake graft, and a lot of times. But going back to what
right here,
you said, I'm with you on, deciding whether we do a connective tissue graft versus a free gingival graft. If you ask any older trained periodontists, they would always throw free gingival graft. But that's because in the past, we believed that only keratinized tissue would gain stability to the tooth, right? That's what we thought, even before the 65, when we Langen low. But anyway, if you read even the Pink Bible, the Otto Zur book, they have a full 2 pages on what really truly gives the tooth stability to the tissue stability, which is connective tissue. The internal connective tissue that's firmly bound to bone is what truly gives the stability to the tooth, not amount of or width of zone of keratinized tissue, but the amount and the quality of connective tissue internally. So I agree with you. You could treat this, even though you may not gain a ton of keratinized tissue with connective tissue grafts, the way you do with FGG, but you will gain absolute stability in these kind of cases. So, the case was treated with a massive bilateral FGG. She had
how was he? I think you told me this
pain.
patient. I think you told me this patient. She didn't
Absolutely no pain, dude. And that's the reason why is the way I do this technique to cover. I mean, 99% of my patients, I swear to you, they would tell you I took one ibuprofen for any harvest size harvest, and it's because the way we stabilize it. So we could use a periacral. But you have to pack it enough. There's no dead space, right? It has to be so tightly packed with your finger that it has no mobility for about 2 weeks. So very little discomfort. So you can argue with the result here. We gain massive amount of attached keratinized gingiva. We deepen the vestibule, and we gain some wound coverage. And in fact,
this is beautiful. Like, this is what gum grafting and Perio is all about. I mean, as we say, we like to call it Perio porn. This is one of them, ladies.
Perio porn, indeed, yes. So, and that's going to stay there for the rest of her life. This is not going anywhere. And even if we look at her a year later, we're probably going to gain some attachment more. We're going to gain some more root coverage because of the creeping attachment. It's definitely going to happen, another millimeter even. So that's the way I treat the Miller 4 defects. Let's chat about your cases.
So for me, I'm going to switch now gears to more implant therapy. What do we do, since now more days we are doing more and more dental implants, and especially like interior cases or even posterior cases. I'm going to have a chance to talk to you guys a few of my interior cases that do come to our practice, where there's consistent soft tissue inflammation around the implants or the crowns, or sometimes you'll see that implants were placed 5-10 years ago, and you'll see that grayness that's showing through the tissue. The question is, well, what do we do to treat it, and what techniques do we treat it? Like Dimitri was saying, you can do Vista technique, you can do open flap approach, you can do tunneling technique. It just depends all about your comfort level and how you approach those cases. So, example, this is a patient who is pretty much, I think she's like 26, 27 years old, had her implant when she was like almost 18, 19. You can appreciate over the years, and just within 6-7 years, that her other teeth have been slowly erupting, and that implant crown, as you can see, it's actually, it doesn't change. So that's a sign where, number one, that crown needs to be changed in the future, because to match, the incisal edges, that's one important thing. But what's interesting about this case is that, she's had a crown. This is a customized a UCLA abutment, but a cement retained restoration. The implant is placed beautifully in the right position, but she's always had this constant source of inflammation since the crown was inserted 6 years ago. She's even had a gum graft at one point in time. What she can't remember if they used donor tissue or her own. That was maybe like almost 2 years after her crown was inserted. But again, so this is what she showed up. This is almost 4 years after her first gum graft attempt, and again 7 years or 6 years after her implant was installed for her. So in cases like this, do you just change the crown and hopefully, and just kind of pray to God that it's going to resolve the problem? The question is, what if there's cement underneath there, since this is a cement retained restoration? So these are all things that you have to look into, and take x-rays, also evaluate if there's any bone loss around that dental implant. Again, dental implants, it's more challenging because, remember, there is the papillas tends to be sometimes a lot narrower. They're sometimes even shorter compared to the natural teeth, just because of the interproximal bone that's associated with those cases. So we decide to gently remove the crown very carefully. I love doing for single cases like this, where especially there's gingival inflammation. I'll do a small vertical releasing incision, and I'm going at the base of my papilla. So I really want to preserve that blood volume to my papilla so it doesn't collapse on me. So I get to reflect it. I get to see what's really going on. In a case like this, there's maybe 1, maybe 2 threads exposed on the facial. What do we do? Our job is to clean it very thoroughly, whether you use titanium brushes, or like titanium scalers, for example. I love titanium brushes. I'll use it sometimes even biologics like EDTA, tetracycline, slurry, just to kind of really debride that implant surface. And sometimes, if in cases, I might even remove the abutment, polish it outside, and then reinsert it back in to give it a nice kind of healthy, clean base for me to work with. As far as materials of choice, it's just one option only. It's autogenous tissue. I don't mess around with implants with donor tissue. It just doesn't work as good. And I feel like there's always going to be a source of inflammation. So you want something that's more resilient, more resistant, that's going to hopefully last for a little bit of a longer time. So what do? We use
Hold on, Fadi, question.
Yeah.
So can you go over your flap design here in terms
So
of
as
this
you
is
can
a
see,
full thickness or split thickness design?
Good question. So I will start, pretty much I started with my tracing incisions, which is very fine. I'm only going maybe 0.5 millimeter into the tissue up to the mucogingival junction. I'm not going really far up and beyond because my goal is not really coverage per se, is just to have enough room for my graft to settle in. So you're going full thickness up to the mucogingival junction. And then after that is partial dissection. So you really want to see if there's any implant threads exposed, and that's going to be only approached with a full thickness flap up to the mucogingival junction. After that, it's partial dissection to allow that tissue to be released gently so you can get at least adequate tissue to cover your graft, so that way nothing pulls back up again if you don't have that little bit of soft tissue elasticity and that release of the tissue. So always go to full and then partial beyond the mucogingival junction. Once you do that, then you see those beautiful pink papillas. I'm going to gently de-epithelize my papillas. Why? Because my new flap is going to sit literally right on top of that de-epithelized papilla. So that's something.
What do you use? What do you use? A blade? Do you use a handpiece?
I will use either usually a 12 blade, or sometimes use a micro scissor, like those Iris micro scissors, or there's many different companies out there that has a really fine tip, and you can just gently kind of snip a little bit off, and it will able to de-epithelize that tissue. So that's something that we do discuss a lot about what kind of scissors that we use, especially in our soft tissue workshop. So I love using micro scissors. You'll see a lot of periodontists, they love using the 12 blade, which is a great one. When it comes to implants, I'm trying to be a little bit more conservative. So I think the micro scissor for me is just more of a safer option.
Yeah.
When I love to use those cases. So then what we do is after that, once the implant surface is debrided, it's cleaned thoroughly enough, I'll put a nice gauze to kind of help control the bleeding and the hemostasis. Then I'll get my simple connective tissue graft. In this case, it's always going to be for me a de-epithelialized free gingival graft. And you can see that some of the papilla has already been de-epithelialized. And I use 7-0 sutures here, which is usually, PGA, which is polyglycolic acid, or Vicryl 7-0. And you can see I have a crisscross suture that goes from the palate towards the facial, biting the periosteum and going back again. That helps kind of put a nice stabilization on the graft itself. And then I will use small interrupted sutures on the side to help kind of stretch the graft laterally as well. So once I do that, it's nice, it's firm, it's stabilized, it's not moving anymore. Then I'll slowly start advancing my flap again. So the question is, when do I put the crown back in? Do I put it now? Do I put it after I sutured? Honestly, there's literally no right or wrong answer. Sometimes I will do it either one. In a case like this, I decide to put it after I coronally advance my tissue and kind of stabilize it, and I'm happy where my tissue is settling. Then I will very gently insert my crown in. And when in this case, I am using very minimal amount of temporary cement. I'm not using a lot of material, because I don't want any cement kind of get shoved underneath the flap again. So you have to be very careful how much you're using, just to get that enough stability in the first 2 to 4 weeks. Once the tissue is kind of more settled down and stable, then you can take it out again, clean it, and then readapt it one more time. That's better fitting. So
question, Fadi, about the flap advancement. So when you're advancing the flap here, do you do a periosteal release, or you just did a muscle release, kind of like a Zucchelli?
Just a simple muscle release. So your blade is almost parallel to your mucosa. That's what it is. So you're allowing that, literally you're detaching the muscles from the mucosal tissue. That gives you the most advancement for your soft tissue cases, to get that really nice root coverage that you're always wanting to achieve. This is very different than the Vista approach that Dimitri was talking, where he goes full thickness all the way to the bone, and he goes as laterally as possible. Mm-hmm. In this case, you're working literally with the superficial and the deep fibers of the mucosa. So most of the superficial fibers, once you dissect that, you get you're detaching the muscles from the mucosa, and you're able to literally kind of gently pull it up with very minimal tension. and that tissue stays there when you have the least amount of tension to it. So that's kind of the key tricks that really helps you get the best results with your root coverage procedures.
Thank you. Perfect.
All right. So as you can see here, I start slowly suturing it up. So again, where do we start with? I usually love to start, and I'll start my papilla first, just to kind of help pull it up. I don't tighten it too hard. Once I have that position, then I will go from pretty much from from the zipper. So I'll go from the top of the top of my incision line, and I'll go slowly in that vertical direction. If I'm happy with my sling suture, I might keep it. If not, that's when I will remove it, and I'll do a better one that has a much better adaptation to it. So that's kind of usually my approach with stabilizing cases like this. So if you see now, my new flap is pretty much literally on top of my old papilla. So that's, after de-epithelializing the old papilla, I have now created a new one. It's called the surgical papilla. So that's the new one that I've created for the patients. And that's going to be the one that's going to be stable long-term, because now you have it sitting on a nice connective tissue bed from your old papilla. So
your flap has to be very, very tension-free, the same way we do for GBR here, because you don't want the retraction of the marginal tissue.
Absolutely. So if you notice here, I have like 2 sling sutures, and they're going literally to the adjacent tooth. So you'll see it on the distal of the central, and the other one is the distal of the lateral incisor. So it's not like I'm slinging it around the abutment. I'm actually slinging them to the adjacent teeth. And why do I do that? Because the adjacent teeth has natural bone. It means that there's natural teeth. It has a higher bone level. So that means I actually can coronally advance it a little bit further versus on an implant site where sometimes you have areas of bone loss. So use your adjacent teeth where the bone peaks are higher, and that gives you even more advancement of the tissue. So it's just a small trick as well that you guys can utilize when you're doing your soft tissue grafting procedures. So again, we gently insert the crown in very, very carefully. So as you can see, this is it at immediate post-op of the tissue. So you have to be very careful, irrigate it a lot. You want that nice irrigation of the tissue, so that, and make sure that the tissue is not too strangled. Otherwise, it will slough off. Remember, this tissue is already inflamed, which means that the collagen content of it is actually not that great. So you have to be very careful when you're suturing it and you're not causing any tears through the tissue. So that's very small key aspects that really gets you good, successful results. So again, 2 weeks post-op, and we remove the sutures at 2 weeks. The Vicryl, as you can see, these are 7/0 Vicryl sutures. They're dissolvable. I might keep them. I might just let them, I might remove them if they're easy to be removed. But at 2 weeks, as you can see, it's slowly maturing. I'm happy with the gingival zenith at this stage. I don't worry about it too much. But if you can appreciate that, the papillas are slowly trying to fill in. Like there was no harm done to the papilla. It's slowly maturing. It's slowly filling in. My goal is that anytime you do those cases, wait a good 3 months. Then I will send the patient to a restorative colleague where they'll do a whole new crown and a whole new abutment, something maybe that's more, if it's possible to do a screw retained or an angled screw access for a case like this. So that way there's less cement that can cause any kind of future gingival irritation. So again, 2 weeks post-op, this is what it looks like. 4 weeks, as you can see, it's healing slowly, even better. The gingival zenith is slowly maturing better with time. Still on the reddish part of it, but again, the sutures have been all removed. Maybe there's one more remaining. The crown is loose at this point. Again, I didn't put too much cement, so it's still in the healing phase. But I gently remove the crown, I clean underneath it. And at 4 weeks, you can appreciate it. This is only 4 weeks later, so nice tissue healing. The papillas are still well maintained. The soft tissue is nice and high. So I just gently clean the abutment. I clean the inside of the crown. I add a little bit more temporary cement, and I gently insert it in and stabilize it. So this is again at 4 weeks. Again, you can appreciate the tissue thickness, how nice and thick it is. Almost no inflammation present at this point in time. So it's again heading in the right direction. Again, for my goal, I'm going to see this patient again one more time at the 3-month post-op. So she's almost 2 months into her treatment. So I think in another month or so, I'll have a chance to, again, evaluate the tissue one more time and kind of hopefully have a chance to also show you guys this case once it's fully finished and completed. But yeah, just to give you an idea, this is what we do when it comes to implant cases. They're definitely more technique sensitive. You have to keep in mind bone level positions with those cases and how we can regain and reform those papillas one more time very, very carefully.
Very nice case. Those are very challenging in terms of maintenance of, and not just papilla, but marginal tissue. You know, you can create a massive recession if things don't go right on that end.
Absolutely. Again, another implant case. I think I've actually posted this case, on our IG, on our Perio Amigos, Instagram page. But what happens if you have cases that, there's missing teeth and also need some soft tissue grafting, and your goal is to have implant therapy involved and helping with that soft tissue remodeling. So I know you have a lot of those beautiful cases that we've able to show in our workshop, but this is kind of something very similar to what we've done. So, a case like this where there's severe periodontal disease, teeth had to be extracted. We did a site preservation first from 7 through 10. But what's interesting is when we were ready to place her implants, she had a huge dip actually right in her nasolabial area, so right around below her nose. So I looked at it, like, man, this is not going to look really well when this is all finished. So we decided to kind of, at the day of implant placement, once we place the implant, we decided to do an additional bone grafting to give her more of that lip support. So that way, when she goes to the final prosthesis, she has nice, beautiful kind of hard tissue thick, bulk, as well as soft tissue with the prosthesis to give her a nice, beautiful lip support, because this is a young patient. So these are things that we always have to take into consideration. A case like this, you can easily put implants in 8 and 9, and then cantilever 7 and 10. There's always more than one way, So there's a lot of that discussion. Well, why don't you put in 8 and 9 when you have so much bone? You can absolutely do that. There's no right or wrong answer. It just depends on what you're used to, what you've done in the past, what's worked best for you. But again, that's the beauty about what we do on day to day. There's just so much more than one technique. So again, another bone graft surgery that we did. These are just periosteal mattress sutures to help stabilize the membrane. So all the sutures are internal in a case like this.
The BioGuide?
Interesting. This is actually 2 membranes.
BioGuide on the left side. On the right side is what?
Straumann Flex. No, Straumann Flex.
Oh, Straumann Flex on the right and left.
BioGuide. I ran out of BioGuide. Yeah, I ran out of BioGuide, and I was like, oh, give me another membrane. So at that point in time, I was just like, let me just do a comparison. Like, what's the difference versus the other? And they're exactly the same. In other words, I didn't get any much difference at all. But it was kind of cool to see a comparison study.
I love it.
So again, we close it up. This is a kind of simple 5-0 using glycolon sutures, and then 3 internal horizontal matrices to really get that primary, so that tension-free wound closure after we release the tissue adequately. So that's our immediate post-op, and just you guys to see what it looks like. 4 months later, now again, we've increased that, that
thickness, huge.
A lot of thickness. So now we've gained that, the bulkness of the bone, and she has actually much better tissue lip support. That's the most important thing for a young patient. I mean, she's in her 40s. The last thing I want to do, her looking like an 80-year-old, because that's something we kind of forgot to look at or neglected to see. So now we're ready, to do our second stage. But if you look at this, we've advanced the tissue so much. Now we need to recreate a new zone of keratinized tissue. So what do? We do what's called a strip graft or a strip-free gingival graft. This is pretty much a partial dissection. Then we stabilize it at the very top, using just simple interrupted sutures for this. And then we'll get a small free gingival graft. It doesn't need to be big, just very small and thin amount enough. And then pretty much anything in between, that will slowly keratinize and transition. Why? Because you have pretty much 360 degrees. It's surrounded by keratinized tissue cells. So that's keratinized tissue. So anything in between it will keratinize. So that's really key when we do strip grafts. It needs to be surrounded 360 degrees by keratinized tissue in order to have no mucosal cells or non-keratinized tissue kind of growing in between. And you'll see like islands of non-keratinized tissue. So
Urban uses mucograft in his cases. It's a Esteban Urban technique that.
Yeah. So this is pretty much I learned this technique exactly from Urban after I took his course in Budapest. So I think in this one I don't believe I used a mucograft. I think I was run out of it, or I might have used just a collagen sponge. or
Yeah, collative works just fine.
I think that one I've used, if you use a collative and maybe use periacryl just to stabilize. Again, this is almost a 3-year-old case at this point, or 2 years old. So again, this is after letting the soft tissue heal, and then we do our second stage. So you can see that nice strip, tissue of that FGG. That's up in the mucosa, really up and high. It won't show in her smile line. So that's really important. And everything else, everything in between has been nicely keratinized with her own natural tissue color. So that when she smiles, it blends in very beautifully and aesthetically as well. So now we go.
Huge thickness, man. Definitely no more dip in the mucolabial fold, whatever.
Absolutely, and I tried so hard to cover those canines, but again, she does have a history of periodontal disease, so she does have bone loss. So again, I think I've tried to cover those canines maybe 3 times, and
it's a Miller 4 defect. Miller 4 defects cannot be predictably covered.
It's a Miller 4, so we have our limitations on how much coverage we are able to achieve. But again, this is the final product. So this is when it's all healed and done. This is the final prosthesis that's screw retained in our mouth. So you can appreciate there's a nice band of keratinized tissue. It's also, you can appreciate that nice tissue thickness that's giving it more of a natural emergence of the final prosthetic. So, she's happy with the result. It's been almost now 2 years in function, I would say. But again, they did a really great job. I think they even did some restorative on that canine to kind of cover some of those exposed roots when she was all said and done. So again, I think the prosthesis maybe could have been touched up a little bit better, just from an emergence profile perspective. But all in all, I mean, I think the results they're very stable, good healthy tissue, stable bone, and that's the objectives when you have those more complicated cases that you're really trying to recreate gum, recreate bone, and also that emergence profile. So that kind of gives you guys an idea, as far as what we can do on tackling those cases. All righty.
Beautiful.
All right, moving forward to one of our last cases, and we have a couple of bonus cases as well.
I'll let you guys totally do this case. Doing great, then we'll chat. I just wanted to.
Sure, this is the last case.
Yeah, if you guys shared, so you guys, the Perio Amigos always over deliver, like extra tequila in your margaritas. So if you
already know
live, keep watching these guys. But the CE code for live C is Evolution 919, Evolution 919. Or if you're watching in, just text CE to 215-543-6454. Text CE to 215-543-6454. It will give you exactly back the code and how you can get C for this. But I'll let these guys keep going. I'm going to interview them at the end. Doing awesome, guys.
All right, this is the last case, and we'll have a chance to do the interview after that. So this is the last case. Again, this is one of those cases, again, another implant case. But if you guys look at this implant was placed about almost 10 years ago. She was 18, and now she is exactly 28 years old. But you can appreciate what happens over time. That bone thins out, and you can start seeing that grayness of that implant. So a lot of questions get asked to me, well, why didn't you do a bone graft? Why didn't you reflect and put a bone graft and add that bone? And the question is, yes, you can do that. There's absolutely, it's not a wrong answer. You can really build that bone. The question is, will that bone remodel again? Will the patient start losing that bone another 5 to 10 years? And the other big question is, if you decide to do a bone graft, will we be able to maintain that papilla effect that she currently has? If you look at her papilla, it's very tiny, it's very skinny, it's very short. And the way they designed that crown on that lateral, they literally kind of did not follow the normal architecture of what a lateral should look like. It's actually more wider at the gingival margin area. So if you try to reflect that completely, there's a very likelihood you will lose that tissue. Oh, 100%. Yeah. I mean, this is a very risky case on a 28-year-old patient. So you start have to think, well, what's the best way for me to approach something like this? So
how's the smile line here? How's the smile line?
She has a high smile line. She's a she's a beautiful young lady with a very wild smile. I was like, it's one of those cases where when I saw this, like, you're going to see a prosthodontist after me because someone needs to change that crown for you, and it needs to be looking perfect like your natural teeth. So I mean, it's those complicated cases that we're seeing more and more because those implants were placed 10, 15 years ago. And now this is the long-term outcome, especially those anterior cases that we're really starting to manage more and more in today's cases. So in a case like this, there's, again, several ways you can do a Vista. What Dimitri mentioned earlier, very predictable. One of the easiest ways to approach this was Vista. I did not decide to take it a hard way. I decided to tunnel this from the.
It's not always. You guys, you got to bring it up. That tunneling around the implant, especially tissue there, is very challenging. No matter what you do through the sulcus, through the vestibular axis, it's very challenging to reflect buccal tissue because it's so fibrotic. It's like we're reflecting a leather belt that's attached to. It's like skinning an animal. It's impossible
It is very hard. It is very, very. So you have to be very careful with the materials that you use.
Slow and steady.
Exactly. And what tunneling instruments, micro instruments, you have to be very careful and gently kind of have your both hands, one on the instrument and one on the lap, and just gently kind of play around with the tissue. So you're not causing any, because you're pretty much what Dimitri was saying. It's very fibrotic. A lot of times your instrument can literally just puncture through it. So
you put a lot of tension, you put a lot of pressure on it to advance, but I always put my finger on top of my instrument, and what I'm feeling as I'm advancing, just like you said, to make sure I'm not going to exit and create another hole.
Exactly. So that's, you need to be very careful. And God knows how many times I've done those holes. I mean, you just have to be very careful, suture it again one more time. But again, sometimes those cases can be very, very challenging.
Do you use microblades at all, Fadi, in these
in this case? I actually did. I did use a microblade. One of the ones I think was like maybe a Beaver microblade or the MJ.
Beaver, with both ends cutting, both cutting ends.
Yes,
it's like a U shape, but both sides are cutting.
Exactly, U shape with both cutting. Those ones are amazing. You just have to be very careful when you insert it because they're both cutting. So, and it's more of a wider one. So you have to be very careful when you go in and slowly dissect that tissue. So a case like this, you're pretty much tunneling through the canine, you're tunneling through the central, and then you're almost connecting them together, kind of bridging them until you get into that implant site. Once you do that, that's your occlusal shot, and you can appreciate how much bone remodeling has happened over the last 10 years because of that implant, So this is a part where a lot of people who do PET cases, partial extraction therapy, it prevents from something like this happening because the body thinks that the tooth is still there. But then just give you an idea when you're doing specifically implant therapy that, outcomes like this is really expected 10 years later, or sometimes even as early as 5 years later. So again, I get a de-epithelialized free gingival graft. Again, that's my go-to for implants and pretty much for almost all my soft tissue cases now, anytime using autogenous tissue. And then we just kind of gently snake it in through the sulcus of your central.
It is not that easy to snake anything through a tiny sulcus, all right?
It was the hardest. This is the part where it's a good idea to think about your friend Dimitri's, maybe I should just drop in a small vista and insert it through. It's much easier that way.
Hey, you will not lose any sleep if you just do that later, okay? You're not going to lose manhood. Just put a vestibular incision even after you tunnel through the sulcus. Just drop it and put it in, okay?
I cannot agree more. So again, this is the immediate post-op after I was able to snake that in. I still don't know how the hell I did it. So I was like,
how? Where did you stuff it through? I mean, how?
I went through the central incisor.
It's like putting a sock on a rooster, dude.
I went through this literally. So as you can see, there's a lot of sutures in here. So I actually use the sutures, the suspensory sling sutures that was described by Marcus Uzer and Otto Uzer in their pink Bible. So I have one on either side. So these are the two lateral ones and one sling in the middle. So just kind of gently curling, but again, very minimal tension on that tissue.
Fadi, looking at this, to me, it would be a little bit worrisome to see those lateral sutures going over the papilla tips like this. What are your thoughts on that? I mean, I've had some cases.
This is a good question. This is a suspensory suture that was, the same one that Marcus Uzer and Otto Uzer used.
Yes.
So this helps actually, if anything, pulls up the papilla. So there's no tension on the papilla. It's all at the base of the papilla. So that's what it is.
Yeah. Okay. Okay.
It's
Just
very
so it's
minimal.
not supposed to go in the sulcus. It's supposed to go over the tip of the papilla.
Yeah, so it goes at the base of the papilla and it wraps
Yeah.
around into the pretty much into the contact. You pick up the palatal and goes pretty much the same way from palatal to the facial, wraps around
Okay.
and you tie it up. So what it does, it helps kind of release after you release the papilla, it just kind of helps pull it up into the contact a little bit. So so there's no tension on the tip of the papilla. Everything's at
Got
the
it.
base of it.
Got it.
Yep.
Very cool. Yeah,
So
don't do
this
this
is a
with the
better
sling
picture.
suture because I feel like sling suture, if you do the conventional sling, that will push the papilla
Oh yeah,
down.
it definitely
If you
pushes the
look at all.
papilla down. Yeah, so you have to be very careful with implants. You have to actually use a different suturing technique in order to really minimize the tension on the tip of that papilla. So if you can see here, that's your sutures on from that occlusal aspect. Again, this is your 4-week post-op. So this is when I removed the sutures, as you can see. So it's nice, it's stable, it looks really good. That's your occlusal shot. And you can see the bulkiness of that connective tissue graft. So very thick and bulky compared to our pre-op pictures where you saw that dip. And I do have actually the 3-month post-op. I just need to upload it for this patient. And now she's getting her crown, finally restored at this point in time. So I can't wait to see her final the final product. I know the prosthodontist reached out to me. She said that the tissue looks very healthy and beautiful, and that she's delivering her final product sometime.
Do you think this implant was placed too shallow at all, or on
it was. Like if I show you the X-rays, definitely placed too shallow and too far facial as well.
Yep. Yeah, that's a lot of, especially the laterals, like a congenitally missing laterals. You got to really make sure you understand the depth of placement. Kind of like a case I posted, if you just place it at the crest when the congenitally lateral, you're going to be absolutely in a bad situation from an emergence standpoint and soft tissue development.
You have to be very careful with anterior cases. Depth and positioning is the key thing in long-term success and able to maintain that nice aesthetic profile and emergence profile for those cases.
100%. 100%.
So I'm going to leave it to questions.
Great. Well, you guys did amazing. You're the Perio Amigos. You cannot be stopped. Only hope to contain. That's like an ESPN line. So you give them an hour, you will pick it in 90 minutes. So amazing lecture. I put in here. This is live CNTV. We have more live CNTV coming up. We have an implant course coming up on September 29th. Another CE on TV show. Just text implant to 215-543-6454. But what I want to talk with these two awesome guys about is they just came to Philadelphia to do their hands-on soft tissue grafting course. They're coming again in November with Team Nacho. I have in here the Eventbrite link, Fadi. I have that. And you have a discount code. So if you want to come see everyone in person, let's see here. I'm going to put in this. And the discount code is Nachos. Thanks for naming it off after me. What is going to happen at this course, Dimitri? Give us a summary of the 2 days and what people are going to learn and what they're going to get to do hands-on.
The 2-day course basically covers what we covered. Today we covered like a snippet of procedures that we do. We covered like 3 procedures, I think, out of many, many procedures. So we're going to cover a boot camp worth of material for 1 day, and a boot camp worth of clinical kind of a hands-on on the pig jaws experience, preparing the bed, harvesting the graft, securing the graft in various ways. And it's all done within, like a very full 2 days in a beautiful hotel in Philadelphia.
You guys pack a lot in. It's a lot of fun. It's a lot of learning. The people who did it last time truly enjoyed it. Don't miss out on this opportunity. Use the discount code. You guys are coming in again. What are some of the people who've taken these courses, Fadi? What do they report going back to do? Do they use these skills around implants, around teeth? How do they use them?
So actually, it's amazing. Like after we gave the course, I've had like 3 or 4 people already text me, "Hey, check out my case I did literally 2 days after the course." I was like, "Man, that was quick. You guys really apply."